Again, thanks everybody for being here and welcome to the Iowa Cancer Clinical Trials Virtual Roundtable. My name is Kelly Wells Sittig. My pronouns are she and her, and I have the pleasure of serving as the Executive Director of the Iowa Cancer Consortium. The purpose of the Clinical Trials Roundtables, if you have not been with us before, is to connect cancer clinical trials researchers, stakeholders, and networks in Iowa in hopes that ultimately we can find more and better ways to collaborate within and across our individual networks and systems. Today, specifically, we are going to hear about a collaboration, a partnership between the Association of Community Cancer Centers, or ACCC, and the American Society of Clinical Oncology, or ASCO, to address common barriers to clinical trial implementation and recruitment, and to develop strategies to improve equitable representation in clinical trials. Our presenter will share for about 25 or 30 minutes, and then we will open it up to Q&A and discussion. And so now I'm really pleased to introduce our speaker today. Janelle Schrag is Assistant Director of Research Programs for the Association of Community Cancer Centers, or ACCC. And Janelle, we are so pleased that you are here today to talk to us about your collaboration. Welcome, Janelle. Thanks for being with us.
Thank you so much, Kelly. It's great to be here. Hi, everyone. Again, my name is Janelle Schrag. I'm the Assistant Director of Research Programs at ACCC. Today, I just wanted to tell you a little bit more about ACCC and the initiatives that we're doing to advance equity in cancer clinical trials, specifically talking about our collaboration with ASCO, like Kelly mentioned. So specifically, I'm going to first discuss a little bit about ACCC and our research institute, as well as some common barriers to clinical trial implementation and recruitment that we recently identified in a 2021 survey, just for a little bit of context for the work we're doing and our collaboration with ASCO. Then I'll talk about some of the strategies to improve equitable representation in clinical trials, specifically those that are featured in our collaboration with ASCO. First of all, for those who aren't familiar with ACCC, we are a national association representing 28,000 practitioners, from clinicians to researchers, the full multidisciplinary team, and that includes more than 2,100 cancer practices and programs across the country. Our membership is quite diverse, so while we are called the Association of Community Cancer Centers, we try to think of ourselves more as a community of cancer centers because our membership does include larger integrated health networks and academic centers. We also really focus all of our work on the how-to side of things, so we don't produce clinical guidelines or anything along those lines. We really think about how to best implement new practices or treatments into oncology care. Like I mentioned, we are a multidisciplinary association, so here's just a quick breakdown of our membership, and you can see it is quite diverse. And then a few of our focus areas. One is closing the gap in cancer research. That's what I'll talk about a lot today. We also, like I said, really focus on the multidisciplinary approach to cancer care, as well as adapting to the future of oncology. A lot of that now is falling in the precision medicine space, as that's really kind of where we're seeing a lot of the new innovations coming out. So that's a huge focus area for us. So like I mentioned, closing the gap in cancer research is one of our focus areas, and we have recently launched our ACCC Community Oncology Research Institute, or ACORI, to really house all of the work that we're doing. And this started following the tenure of our immediate past president, Dr. Randall Oyer, who's from Penn Medicine Lancaster General Health. We have a president every year from March to March, and Dr. Oyer's president's theme really focused on increasing participation in clinical trials in the community setting. So both community cancer practices having more of a footprint in the clinical trial space, as well as increasing representation of patients from communities, rural areas in clinical trials. His president's theme featured a lot of education programming, webinars, newsletters, the beginning of the collaboration with ASCO, as well as an education project. And once his presidency concluded, we really saw that this is an important area to keep moving forward. And so we decided to launch ACORI. And our three focus areas under ACORI are first equity. So really thinking about increasing the representation of historically marginalized groups into clinical trials, as well as, like I mentioned, groups from rural settings and the community in clinical trials. Secondly, capacity building. So really focusing on how we can build capacity among community oncology sites to be ready to engage in research and implement trials themselves. And then research diffusion. So bringing the findings from clinical trial research back to our membership, as well as opportunities to get involved in research. And so some of our featured initiatives under ACORI to date are the ASCO ACCC collaboration, which I'll spend most of my time talking about today. We've also recently launched a clinical trials research glossary. I'll talk about that on the next slide. And then we also held an inaugural stakeholder summit last month on September 13th and 14th, which was really focused on action planning for our next steps under ACORI, with specific focus on what ACCC and sponsors and our partners can do to really focus on increasing participation in clinical trials, that health equity piece, really engaging patients in clinical trial design and conduct, and then also community engagement. We do have an executive summary that is in the works from that stakeholder summit. So hopefully we could maybe circle back with you and share that with you once it's ready in a few weeks. So here's just a quick look at our clinical research terms glossary. This is hosted on our website. I highly recommend checking this out. It is meant to be provider facing, as that's our audience, but it is in lay-friendly language. So it is a tool that could be used with patients. We have over 400 terms in the glossary related to clinical research, and hopefully a very cool interface that you all will appreciate. And then we also have recently launched our ACORI community group on our ACCC Exchange discussion forum. The discussion forum is a benefit of ACCC membership, but we do have this discussion group open to members and non-members. There just is a small process for getting approved to join, but all of this is on our website, accc-cancer.org/ACORI, if you want to take a look at this and potentially join our discussion forum to kind of join the conversation about clinical trials and increasing clinical trial enrollment. So during our summit back in September, we did present some findings from a survey that we conducted over the summer. And I'm not going to go over all of those findings, but I wanted to share a few of the highlights specific to the barriers related to clinical research that we identified. I think this might help set the stage a little bit for some of the work we're doing, as well as the ASCO ACCC collaboration. So first of all, during this survey, we asked respondents to indicate their greatest challenges related to cancer clinical research. And the top barriers that came through were available trials not matching the patient population, limited number of staff available to participate in research, and then maybe of the staff who are available, that staff not having quite the necessary training, and then limited finances to open or run trials. And we did look specifically at the responses from just the community practices who responded to our survey, which was a little over 50% of respondents. And we did see some different barriers come through among that group, specifically having limited diversity among enrolled patients, limited access to information about clinical trials, which could be opened at their site, difficulty recruiting patients, and competing cancer practices or programs in the local area. So maybe losing patients to other sites who are offering clinical trials. We also asked our respondents about how they're engaging patients in research design and conduct, as this is something that we're hoping to promote and provide resources for. We did see that about 45% of respondents aren't currently doing this type of activities, but of the 55% who are, about 21% are doing so through community partnerships. And we asked respondents to tell us a little bit more about the education and resources that would help them related to clinical trials and oncology clinical research. And this was open text, but the main themes that we saw come through were educational materials for patients, both to use in clinic and out in the community, tools and resources to increase capacity, specifically staff, IT, and training, and more accessible information about trials, specifically improved searchability, like on sites like ClinicalTrialsgov, more clarity from sponsors about trial eligibility, and into better integration with the EHR. So I'll be anxious to hear from you all later if any of these resonate with you, or if you've had specific challenges related to any of these. I will say, before I move on, this was a very small sample size. Our sample size was a variable N of 31. So we are hoping to redistribute this survey next year and would love for you all to participate in that. So now I will shift gears and tell you a little bit more about the ASCO ACCC collaboration. So formally, this is our initiative to increase participation of patients from racial and ethnic minority populations in cancer treatment trials. This is something that really grew out of Dr. Randall Oyer's president's theme, as well as ASCO's immediate past president, Dr. Lori Pierce. Both of their president's themes really aligned on increasing participation in clinical trials and increasing enrollment of historically marginalized groups in clinical trials. So it was a pretty natural fit to collaborate. And the goal was to establish practical strategies and solutions to help increase participation, again, amongst those historically underrepresented groups. We did focus specifically on Black, African American, and Hispanic or Latinx populations to begin, because this is a pilot study. We know that there are plenty of other groups that have been historically underrepresented and really do need to have more representation in clinical trials. But for the sake of the pilot study, we did focus on those populations to start. So this began back in 2020, where we started with a request for ideas. We received about 27 submissions, 10 of which were considered, and that was just because some of the ideas that were submitted weren't quite developed enough for us to move forward. And so of those that were reviewed, we selected 2 of the submissions to move forward in developing some strategies. So the 2 that were selected were first a quality improvement training program, which was led by Dr. Carmen Guerra out of the Abramson Cancer Center. And so her proposal included components of site introspection and training, which were based on some of her previous work on an ENACT study. And then the second selection was a Research Health Equity Index, which was led by Alice Pressman out of Sutter Health. This was pretty early on and not quite well developed, but we did think that some of the concepts and strategies were really a good fit for the goals of the project. So what we ended up doing was taking those ideas and kind of shaping them a little bit more into 2 specific strategies that we could develop and test, with our focus areas really being introspection. So thinking about what sites are doing and how, how they're performing when it comes to recruitment of underrepresented populations in clinical trials, and then moving forward to remediation and improvement. So the 2 strategies that we decided to develop and test were first a site self-assessment tool to assess site practices, programs, and screening and enrollment practices. and then also an implicit bias training to address biases associated with who is offered a clinical trial. And I will say that the development of both of these is very much informed by both a steering group as well as a patient advisory group. ACCC leads the implicit bias training portion of this, so I'll probably have a lot more to say about that side of things. And ASCO is leading the site self-assessment tool. We work really closely with them, so I'll tell you about both, but if it seems like I lean heavily on the implicit bias training, it's only because that's what I've been living and breathing for the past 10 months. All right, so a little bit more about the rationale behind both of these strategies. So we did see in our literature review and just the data that's out there that one of the greatest barriers to clinical trial participation is just that trials are not being offered to patients. So this idea of just ask patients about clinical trials. We see some of that specifically in a study by Unger et al., where of those who were offered a trial, 55% accepted to participate, and that didn't have any dependency on race. That was just, if you were asked, people most often did accept to enroll. So that there's more information that we needed to collect to understand these factors at the site level, both in terms of the practices that are happening in enrollment in clinic, as well as any implicit biases that might be factoring into whether or not a provider asks the patient to enroll in a clinical trial. So here's just a high-level look at our overall process of implementation. We're currently in our first phase, which is to develop and test these strategies. We are considering this a pilot study, specifically to look at feasibility and utility of both the tool and the training. Although we are hoping to soon move this into a phase 2, a broader interventional study, where we can really take a look at the impact of both of these strategies, because that's, our long-term goal is to really see how these influence practice behaviors and knowledge. Here's a little bit more of a detailed look of our phase 1 timeline. So we are moving forward with the tool and the training concurrently. We have development, beta testing, and then are currently actually at the end of our evaluation phase, soon to move into our synthesis phase. So both of these are just about wrapped up with our main data collection, and we'll be moving forward with kind of revising the tool and the training. So this is a good point in time to talk about both of these, because we're pretty well wrapped up with the majority of the activities. So all of this started earlier this year with recruiting our sites to participate in both the tool and the training pilot studies. There's more information about this on our website. This is actually just a screenshot from our website, but we have 75 research sites participating in this pilot study. We originally only set out to work with 40 to 50 sites, but we had 75 sites apply, and we were very happy to be able to accept all of them into this pilot study. So we currently have some different cohorts. There's about 10 sites that are just doing the training, about 25 sites that are just doing the tool, and then a cohort of about 50 sites that are doing both. All right, so I'll tell you a little bit more about the implicit bias training. So when we started developing this implicit bias training, we thought it was really important to first kind of clarify what we were talking about, because implicit bias can kind of be a nebulous term. I think obviously folks know what it means kind of intrapersonally, but we definitely wanted to approach this from all the layers of implicit bias, both within oneself, but also how that plays out into society. So we were really kind of approaching this with biases being the stories we make up about people before we learn who they are, and that everyone has bias. So we've really approached developing this training of there's no shame around this. Everyone has bias. It's really just a matter of what we do to mitigate those biases and how we let them play into how we interact with others. Just some examples of bias from the implicit association test. Of about 10 million tests, you can see 75% of the population has a pro-white, anti-Black bias. 50% of the US population who identify as Black have a pro-white, anti-Black bias, and 76% of the US population, including men and women, have a pro-male bias. So those are just some of the things that culturally are ingrained in us as implicit biases that are important to address, particularly when we're thinking about clinical trial enrollment. And the graphic on the right, like I said, kind of shows those layers. So intrapersonal within oneself is, our bias is how we accept racist bias beliefs to be true. Moving into interpersonal, that's how that plays out with others. So prejudice, discrimination, and microaggressions. But then there is this broader context of structural and systemic racism, like laws, policies, and practices that are the much bigger picture. And we have to keep that in mind when we're thinking about mitigating implicit bias in clinical trial enrollment. Just kind of to take that further into the clinical research setting, we can see some examples. So interpersonal, that would maybe be some misconceptions about certain patients' ability to participate in clinical trials, which might lead to them not being offered a clinical trial. Interpersonal, so that kind of playing out with lower clinical trial screening and accrual, specifically of Black, Indigenous, and people of color compared to white peers. And then at the structural or systemic level, an example of this is Medicare and Medicaid not covering out-of-pocket expenses for trial participants. I put a little asterisk there because obviously this has recently changed. We do now have legislation that will take effect in 2022 so that for Medicaid populations, they will have out-of-pocket expenses covered. So in developing the training, we actually relied on a curriculum that was already in existence called Just Ask. This was developed by Nadine Barrett out of Duke University. And so the Just Ask training was really around engaging patients and communities and research teams with the idea of just ask a patient about clinical trials. So we decided to take that and modify it slightly to be more aligned with the oncology research team and full multidisciplinary team. We added some case vignettes, but the core curriculum of the Just Ask program stayed the same. And so we developed this into an online learning module, which is on ACCC's website and will be publicly available early next year. And this is kind of just a look at our timeline of the training program pilot study. So before we even had everyone go through the training modules, we also conducted what are called chart stimulated recall interviews. We did this with a small cohort, and it's basically an interview with a provider where we pull charts and we go through the chart and we go through the characteristics about the patient and the visit, and we see if the clinical trial was offered or not. So we did 10 interviews, each included 5 charts. So we had 50 charts total. And we did see that in those scenarios, most of the time a clinical trial was not offered. We're still finalizing that analysis, but it did provide some pretty striking context to the rest of the training of kind of what's happening in practice. And then, like I said, between August and September, we had the participants go through the training modules. This was self-directed. And then on September 15th, we convened everyone who was participating in this. And we just used the time to talk about their experiences and their lessons learned from the training. This is an important component of that Just Ask curriculum, is to have that dialogue, because it's really great to learn something on your own, but when you're able to connect with your peers about it and share experiences, that's kind of really what solidifies those lessons learned. So we really wanted to make sure we included that component as part of this program. We did have an evaluation that was sent following that meeting, and then have a second 6-week follow-up evaluation that just went out this week. So this final step is currently in progress, and then we are getting ready to start our data analysis. And now shifting gears to the site self-assessment tool. So the site self-assessment tool really has two key components, which really tie back to the objectives of this collaboration, which I spoke to earlier. So one being site introspection. So really looking at how a site is performing across the entire clinical trial enrollment continuum. So from the moment the patient walks into the door, from the time that they leave the clinic, what's happening there when it comes to clinical trial enrollment. And then also looking at the different internal factors like site policies and procedures that may have a role in screening for clinical trial eligibility and then ultimately moving towards enrollment and participation. And then the tool also includes a lot of feedback on specific opportunities and strategies that could be used for improvement. So here's kind of a look of the components of the tool. Like I said, kind of moving across that continuum and thinking about introspection and solutions. So there is a component of looking at the community and site profile information. So, one thing that we really talked about a lot is this starts with just the patient walking in the door. Are we actually engaging communities and getting patients in the door before we can even talk about clinical trials? So we are looking a little bit at the community characteristics and demographics and how that compares to who the actual patient population is. And then looking at the site performance, this is kind of the main self-assessment piece. So patient access to the site, how patients are screened for clinical trials, if patients are offered clinical trials, and then if they move through to participation in clinical trials. And then thinking about the opportunities for improvement, so structural and systemic procedural factors, so at that organizational level, attitudinal factors. This kind of ties into the implicit bias training as well, so kind of what's happening in the culture in the institution amongst providers, staff, and patients. And then providing other strategies to improve outcomes, specifically around access, screening, offering clinical trials, and then enrolling and participating in clinical trials. Throughout the tool, it's a very big online survey assessment that people go through. There is kind of some performance outcome scores. The different domains of the tools are scored, and there's a summary report that's provided at the end so that the user can walk away with those identified strategies and feel like there's something to act on and not just a score that they get. And this is currently also wrapping up data collection. I believe data collection is going to close in the next couple days, and then we'll be moving into our analysis. So again, here's a look at our timeline. Like I mentioned before, we're just wrapping up evaluation and moving into synthesis. And then our goal is in early next year to disseminate both our findings from our analysis, but also to publicly launch the tool and the training. So the tool is currently hosted or will be hosted on ASCO's website. The training's hosted on ACCC's website. It's closed right now to just the pilot study participants, but we're hoping to make that publicly available so everyone can participate in these. And to that note, I don't think we actually have any participants from Iowa, so I hope that you all stay connected with this. We can surely provide updates so that you can come back and participate in both of these strategies once they're publicly available. And then again, I'll just plug the resources we have available on our site, accc-cancer.org/ACORI. That's where you'll find our glossary. We have a resource library, access to the discussion forum, more information on the ASCO ACCC collaboration. We're going to have the executive summary from our stakeholder summit coming out soon. And then if you're not already aware, ACCC also manages the Iowa Oncology Society. The contact for that is Luann Bankert. So if you're interested in learning more about your state's society, feel free to reach out to Luann. And we can move into questions. My contact information is here if you have any other questions. But thank you so much. I really appreciate the time and looking forward to the discussion.
Hey, thanks, Janelle. That was fantastic. I have a few notes that I took. My name is Shannon Benson, and I'm the Executive Director of Iowa Oncology Research Association. I also am the co-chair of the Clinical Trials Work Group for the Iowa Cancer Consortium, and I have the privilege of leading the Q&A time right now. And I guess I'll start with a question. So on the searchability, I know there was you talked a little bit on the ClinicalTrialsgov. I mean, I'd love to hear your thoughts on if you've used ClinicalTrialsgov, how that went for patients, or any any feedback you've ever been given. I know we use that quite a bit when people call our office looking for a trial that we don't have. And as someone who's not only worked in research, but also oncology for a long time, I even think it's challenging. So I'd love to hear what you've heard about that.
Yeah, I think it's really interesting, that data point in particular. We had a number of questions about how folks are finding information about clinical trials. And what was really interesting is people said that they are using clinicaltrials.gov as a primary source and that they feel like it's a comprehensive resource. But then when we asked how it could be improved, there was so many thoughts of people saying, it's not easy to navigate. It's really for a clinical audience, it's not patient friendly. So, some of the other sources that we saw where people were going directly to sponsor websites, whether it was industry or an academic sponsor, or just talking, like word of mouth was another pretty high source of information about clinical trials. We're currently working with quite a few organizations who are undergoing initiatives to embed these types of matching or trial searchability features into the EHR. So hopefully that's something we can provide more information on later. I think we're working with 4 or 5 different organizations on that right now. So hopefully, that's something that will make it easier for everyone in the future. But, I'd love to hear from others on the line if they have other thoughts about clinicaltrials.gov as well.
It is very clinical. And I also think if you're a patient, you may know you have lung cancer, and you might even know the stage, and that's not going to get you very far as actually finding a good clinical trial for your exact. I mean, I just think it's such limited information that they usually know, especially if it's a new diagnosis. They have a lot that they're working through at that time. It's hard to keep track of all of the reports and things, even if they're given those. So
hey, this is Jill Strike. I'm in industry, but I also have been trying to navigate a brother-in-law's metastatic colorectal cancer. And even as someone from industry, now granted, I'm not a nurse, but just navigating clinicaltrials.gov has not been easy. He's used the Tempest testing, which they usually, bring back, like when you get the report, you get potential trials, but even to try to use the system when I know the mutations to see if it's an off one that's, someone's studying, it's wherever it is. His cancer is pretty rare. So we're searching for anything. It's not user friendly. It's been rather difficult. So I would agree with you, Shannon. It's difficult.
Janelle, I wondered about, you talked about educational materials for patients. Do you know if it was trial specific to trials? A lot of times that, at least at our institution, some of that has to be institutionally or approved by our institutional review board. Anything that's a patient handout, is that something that you guys had considered or that you thought would be the route that you would take with those materials?
Yeah, but this is an area that we're exploring more, thinking about future education that we might be able to provide. I will say we've gotten a lot of clarity on that as well from our patient advisory group. We've had very rich discussions with them about just the general information publicly, like public knowledge that needs to be raised about clinical trials, because there's kind of a misconception, a natural misconception that trials are only a last resort and they're not a standard of care. So we've been talking a lot with them, our patient advisory group, about different marketing that could happen either in clinic, in communities, at the public level. So I think we're going to continue to keep exploring that and seeing what we might be able to do to provide some materials to our members and maybe some of our partner organizations. Although to your point, we will have to be take into consideration any institutional requirements about providing those kinds of materials.
So I'd love to see in the chat if anybody has, I know Kelly mentioned this earlier as well, if anybody has actually taken an implicit bias training. Be interesting to see if anybody has done that. I think it would be worthwhile. I think I saw on a show, it was actually talked about on a show recently, that they gave an example, and they said that if you have a problem with your tire and you pull over and the person that stops is a woman and you're kind of like, oh, well, this isn't going to be very helpful, then that's implicit bias. That was the example they gave, that, just even thinking, oh, well, this lady probably can't help me change a tire, and I certainly can't help anybody change a tire. So that would be accurate in that case, but that was interesting. So if you've ever taken one, I'd love to see that. Someone drop it in the chat.
Janelle, I'm curious if you have a sense of resistance to some of the implicit bias pieces from any of the teams that you worked with.
Do you mean like resistance to kind of talking about implicit bias, acknowledging implicit bias? Yeah, it's kind of a mixed bag. It was really interesting when we got the groups, the participants together to kind of talk about their experiences with the training. We heard a lot of people say that it was very eye-opening to go through the training, to kind of have an aha moment about their own biases. We do promote the Harvard Implicit Association test through the training, so we encourage people to take it. And I think things like that were really helpful. But it was hard. It wasn't an easy conversation to have. I think, it is naturally a very difficult conversation. It requires a lot of vulnerability to acknowledge in front of coworkers or peers that you have these biases. So it took a little bit of coaching to get people there. I think people are open to it generally, but it can be hard to change that from a personal experience or training that you go through into a larger dialogue that would ultimately be needed to affect change at a cultural organizational level.
So I have a question in the chat, and then we also have a raised hand. So Sneha, thanks for this question. This is excellent. What do you think is one actionable step that nurses or investigators can take to increase diversity or equity in clinical trial enrollment?
That's a great question. I think a lot of this just starts with looking at the data, looking at what's happening at your site. Obviously, that's a main motivator behind the tool that we created. But I think we saw that even in some of the interviews that we did, our chart stimulated recall interviews, that even some of the providers that we were talking to as they were pulling charts weren't even really aware of their own practices, and that the fact that they hadn't offered a trial to a patient for kind of a reason they couldn't explain. So I think it's really important to have that introspection and to first look at what's happening in practice. If it is a enrolling provider, to really look at the conversations that they're having. But even, at the investigator or for nurses to take a look at, how many patients are being enrolled in clinical trials? Does that have any difference by patient characteristics? So race, ethnicity. We also looked at education level or health literacy levels. So really kind of examining the data, I think, has to be the first step, because that really provides a guide on maybe the areas that you can move forward with in addressing.
Absolutely. Mel, your hand is raised. You can go ahead.
Hi, can you hear me okay?
Yes, we can hear you.
I apologize, I can't be on camera. I'm getting ready to pop on another call. Something I was wondering, I'm in a very unique space, rare disease. I have a therapy for acute lymphoblastic leukemia. It's both in the adult and pediatric space. This very conversation came up not long after the George Floyd, and it came up at Children's Minnesota, which for those of you that know Minneapolis are very familiar that Children's Minnesota is within blocks of where George Floyd was killed. the chief researcher there, and again, for those that are familiar with the leukemia space, the majority of pediatric patients that go on a type of therapy for ALL, typically their first line of defense is through clinical trials. So I think it's very applicable to leukemia, for example. And the chief researcher at Children's Minnesota kind of challenged us as biotech to say, you know, what are we doing? Or are we doing what we need to do to make sure that we're bridging that gap, enrolling a more diverse patient population? He said as healthcare providers, they can do better. So I'm just wondering from a biotech side, how is ACCC or Iowa Cancer Consortium working to partner with industry to make sure that we can all be in this fight together? Because I think that we all recognize that there's definitely a miss here and there's a huge area of opportunity.
Yeah, thanks, Mel. I'm definitely happy to start from the ACCC side, but I'll also let Shannon or Kelly comment from the Iowa side. We definitely view industry as a key partner in this. We have multiple industry partners who are working with us under our ACORI umbrella. And during our stakeholder summit on back in September, we actually had a very large industry attendee list and really encourage the conversation with industry as well. So that's definitely something that we will continue to move forward with, is making sure industry's at the table. We also have been collaborating a little bit with FDA, as they can kind of sometimes be the middleman or the at the top, and the industry is kind of the middleman when it comes to trials. So we're trying to just make sure everybody's at the table and is contributing to the conversation so that we're all moving forward together and not working in silos.
Looks like Jill echoed that question in the chat. So I think you've kind of answered her question with that as well. And I mean, I feel like from the Iowa Cancer Consortium, this is a consistent topic. I think in everything that we do, that's, you know, awareness of it from the cancer control piece. How do we improve the equity? And I think that's, I mean, I really feel like it's kind of at the forefront of everything we're trying to do right now. Kelly, you can add to that.
Yeah, I totally agree. And the industry side as well, you know, ours is obviously a different perspective because we're the State Cancer Control Coalition. And so there's a place for almost anybody at our table. And we do have a lot of strong industry partners as well. Our role is going to be more like what we're doing today, the convening and the partner connection and capacity building in some ways as well. It's a great question.
I have one other question, and then if we don't have anything else, I'll kind of wrap things up. But, you know, one thing just even in a personal practice that I have witnessed is because the organization I work for, we screen 100% of new consults. And that wasn't catching everybody for clinical trials because we, of course, have trials for recurrence or new primaries. So then we started screening every single appointment at our medical oncology office. We spend hours screening our patients for clinical trials. And first off, I don't think that patients know that. And that's something I'd love to see. You know, we talked about having something, you know, in their, you know, handed to them that says you were screened for a patient, you know, for a clinical trial, because a lot of times patients just don't even know that. But I guess from a question standpoint, sometimes we find, you know, we find a patient who is eligible for a trial and we take it to the investigator and they, you know, either the investigator and or their staff kind of shuts the idea down immediately and saying, this patient is just really overwhelmed. I just don't think that, you know, adding the option of a clinical trial is a good idea. You know, is that something that you see? Is that something that, you know, you would have ideas on how to improve that? Because it really, I mean, my follow-up to that is wants to be, but shouldn't they be able to say that? Shouldn't the patient be able to say, I'm just too overwhelmed for this? So, but, you know, we just kind of, you know, we're the research staff and we want to give the opportunity to the treating investigator, but we trust that they know what's best for the patient. But sometimes we just wish we could get through that door because that's kind of a door that is closed quickly sometimes.
Yeah, I think you raise a really important point. That's something that we have kind of uncovered as we've gone through pilot testing this implicit bias training, particularly in the chart simulated recalls, that interviews that we did. We saw exactly that so many times a patient is screened, they're eligible, but ultimately there's no discussion had. It's not offered to the patient because that enrolling provider or the investigator is making that decision that the patient wouldn't be able to participate. And we need to move past that. It's the idea that you still should just ask. You have no idea what that patient's situation is, motivating factors are, what they ultimately would decide. So that's really why we're trying to push this idea of just ask, because, you know, we can think about implicit bias as far as ideas around race or ethnicity, gender, or age, but it's also these assumptions that we're making about the patient's personal circumstances, or even projecting some of our own self-experiences onto that patient. So we need to really talk to patients and get to know them as people so that we can offer them trials and have that conversation about participation in a trial, rather than making those assumptions ourselves and just not having the conversation.
I really like that, just ask. I think that's catchy, and it's just, you know, I think that's really neat. Stephanie, yes, hand raised.
No, I just wanted to echo what Janelle said earlier about the patient being able to make the decision for themselves, and the perspective of the trials being not something extra, but actually part of the treatment plan, and then just selecting which treatment plan best fits that person's situation, which is really more of a pediatric hemonc approach, but hasn't really come over to the adult side quite as much. That I think, like I said, you uncovered it, and I'm not surprised that it's more of it's an extra piece. Sometimes it's presented. So yeah, presentation is like, and the scripting, I think, is a huge thing. So how is it being presented to the patient as it, you know, here's what we, you know, has been studied the most. This is what we're doing. We have this other opportunity here, and this is this process. And then again, it's just kind of the model that's been set up in peds, because for treatment studies, the physicians have to be the ones that consent as well. So they kind of had that model built in, which is just a different model, and let alone they see, you know, like the quarter of the number of patients in a day that the adult physicians see as well, which is another barrier to some of these discussions, is just the time allotted to spend with the patient. So it's just, there's a lot of barriers that kind of need to be addressed, you know, that build up to all of these different issues. But anyway.
Yeah, thanks, Stephanie. And I'll just add to what you said, that we did hear that pretty loud and clear through the participants going through the training modules, that they get it, they get the lesson, but they need tools. They need to know how to talk to patients about clinical trials. So that's something that we're hoping to integrate into the public iteration of the training, is some tangible resources of, this is what that conversation could look like. Now, you know, use this. You can say it verbatim, you can change it, but here's some tools to actually have the conversation with the patient about clinical trials.
Okay, well, I'm gonna let Kelly wrap things up. So
Thank you. Thanks, Shannon, for facilitating. And Janelle, thank you so much again for sharing your work with us and your time, and for being here today. And then I also want to tell you a couple important things that the consortium is working on that I think you might be interested in. First is that this year we are offering free LGBTQ inclusivity trainings for rural cancer care providers. If you're not a rural cancer care provider and would still like to receive the training, definitely reach out to me, because I think we have a little bit of flexibility with that. So One Iowa offers these amazing healthcare inclusivity trainings, and the consortium is able to sponsor quite a few of them for members and partners this year, especially in the rural areas. So drop me an email if you would like to know more about that, and I'll connect you with the right folks. And then I want to share that the consortium's policy committee is putting together, and I'm going to put the link in the putting together a document that is meant to be like a collective resource, a living document that provides resources focused on policy that can be used to reduce the cancer disparities that exist. So they want to have for members and partners and key legislative champions a whole bunch of resources collected that folks can use to see how policy can help to reduce cancer disparities here in Iowa. So feel free to take a look, but also to contribute your input and questions and comments and resources. Go ahead and edit the document. Reach out to me if you have questions. You can edit that through November, and I'm sure we'll share it widely once it's ready to go. And again, it's meant to be a living document, so it's probably something you'll see again in the future. And with that, I'll just say thanks so much from the Iowa Cancer Consortium. If you're not a member, I encourage you to go to canceririowa.org and sign up to be a member for $0 to $20. So that you can make sure you're getting all of the information about sessions like this, about implementation grant opportunities, about ways to connect with the network, which is we're excited to say, over 500 members now. So please reach out if you have questions about any of these. I'll pop my email in the chat. And otherwise, have a really, really lovely rest of your day. Thanks, everyone.